Hey, it's Tim from ChiroUp. Our patient comes in and they have hip pain. That tells us we need to take a look at the hip. So today we're going to go through a relatively comprehensive exam of the hip. We'll check range of motion first. We're looking for extension. Is it at least 15 degrees? Usually flexion is about 125 degrees. External rotation is going to be at least 45 degrees, maybe closer to 60, and internal rotation should be 45 degrees. If the patient doesn't make the internal rotation, we're suspicious of hip osteoarthritis because that's the first range of motion to go away. We can also look at abduction. So those are the active ranges of motion, but we can also do this passively on the patient. Our straight leg raise takes a look at how tight is the hamstring. Can we get that patient to 90 degrees? A great test to look at the psoas is Thomas test. That's having the patient bring one knee up toward their chest and watching what happens to the other leg. Ideally, that other leg would stay flat on the ground. It wouldn't lift up. When the patient pulls the upper knee up and the other knee comes up, it tells us that there's probably excessive tightness in the psoas. And then don't forget Ober's test. That's in a side lying position. In this case, we take the patient's leg, we have them abduct it, extend it a little, and see can they drop that leg to one knee behind the other. If they're not able to do that, there's probably some tightness in either the tensor fasciae lata or the gluteus medius. We can also look at resisted range of motion testing, most notably the psoas. So again, the patient's on their back, and for Stinchfield test, we have that patient bring their leg up to about 45 degrees, hold it there, and then I'm going to push down. That's twice the force of the patient's body weight going through the psoas. If somebody has a psoas tendinopathy or some irritation, that's probably going to light it up. We could also do that with the patient either sitting or long sitting, and that would be called the Ludloff sign. We can take a look at extension of the hamstring. So again, having that patient bring their leg up and now push down against my resistance. And then we can do that with the knee bent. Pull your heel towards your buttock. That gives us a good assessment of is there any irritation to the hamstring or the extensors of that area. We can test the adductors with an adductor squeeze test, having the patient squeeze their legs together, and then side-lying abduction. If the patient gets on their side, they can bring their leg up and I can push down to say what's happening to the adductors. To the lateral hip abductors. The adductors, if we have the patient do a squeeze test with their legs straight, we're largely testing the adductor magnus. If we have that do with their knees bent about 60 degrees, now we're testing the adductor longus. So we can drill down just a little bit with that one. Now, our palpation, we're looking at any of the tender spots, especially on a young kid. Is the iliac crest, the ASIS, or the AIIS tender? Because we could be looking at a traction apophysitis where something is pulling away from there. We'll also think about pubic symphysitis if this is an athlete or especially a female who might have had a child recently. There'll be tenderness in that area. Sometimes you don't want to palpate that, so it's easier to have the patient palpate that themselves. If they note that there's tenderness, we're getting the same information from that. While we're palpating the area, the ASIS, we move just medially to get onto the psoas. That's going to be tight and tender in most of our patients with lower back or hip pain. And while we're in that area, if we were midway between the pubic symphysis and the ASIS, if we palpate in that area, we're on the deep inguinal ring. So we could be thinking of a sports hernia or an inguinal hernia in that area. If the patient rolls onto their side, then now is when we're going to see a lot of the real tenderness on the lateral hip. That's where most of our tenderness is. Tenderness over the greater trochanter, or more so where the gluteus medius tendon inserts on the superior aspect of that greater trochanter. That's where almost everybody's going to have some degree of tenderness. The other thing that we can look for is how's the tenderness, if you flip back onto your stomach again. I'm sorry, onto your stomach though, Brandon. And so now we can say, is there any tenderness over the lumbar spine? We can palpate the lumbar segments. We can palpate the sacroiliac joint. And don't forget to palpate the whole length of the sacroiliac joint and even the ischial tuberosity. Is there any tenderness over the piriformis? Is there any tenderness between the ischial tuberosity and the femur, which could be an ischiofemoral impingement? And we'll dive into that just a little bit deeper in a second. We'll also look at what's the range of motion, not just of the lumbar spine, but also of the hip from a motion palpation standpoint. So we can take that patient's leg up, I can grasp their hip and their acetabulum, and then I can apply a little bit of anterior thrust, a little bit of posterior thrust, abduction and adduction to say what's happening in the hip. It's a little challenging to determine the mobility, but we can determine is there some degree of microinstability, is there some degree of hypomobility of that hip joint. Now it's time to dive into the orthopedic assessment for the hip. There are lots of tests that when a patient comes in with this test, it's called the C sign. They make a C with their hand and they put it on the outside of the hip. That alone gives us a good indication that this is probably a hip pain, a hip problem, until we prove otherwise. The other test, if you flip onto your back, is Fai Test. Now, Fai Test is going to be positive in 88% of all hip diagnoses and hip pain cases. And Fai, as its name stands for, is flexion, abduction, and external rotation. Now, that's going to be positive for a lot of our cases. Once we see that, we want to drill down one notch deeper and say, which diagnosis could it be? The first thing that we'll think about is osteoarthritis. Fai Test is going to hurt, but the other thing that's going to hurt is Fai Test, taking that patient's hip into flexion, abduction, and internal rotation. And in that case, if there's discomfort, we're thinking maybe there's some hip osteoarthritis or one of the other diagnoses that we'll talk about in just a second. The next thing that we can do is a hip scour test. In this case, we're taking this patient's knee up to 90 degrees. I'm going to apply some stability underneath their hip and apply an axial compressive force while I grind that hip. I can tell you that Gertrude is not going to appreciate that test, that sometimes we don't need to do that to prove the diagnosis of hip osteoarthritis. Now, in our patient who has FAI, and remember FAI is femoral acetabular impingement, it means there's a mismatch between the acetabulum and the head of the femur. One or the other is egg-shaped. So there are a couple of tests that can help us identify that. The first one is just what we did, Fai Test. Taking the patient's leg into flexion, adduction, and internal rotation is often positive in our patients who have cam-type impingement. That means the femoral head is egg-shaped. Another test that we can do is similar is the hip quadrant test. I'm taking the hip and knee to 90-90 and then lifting his pelvis off of the ground. If that causes discomfort, again, we're thinking of an FAI or a hip impingement. And then finally, the posterior impingement test, which in this case we're going to have the patient flip onto their stomach. And for posterior impingement, we're going to take the leg into extension and then some degree of external rotation. If that causes discomfort, we're thinking of more a pincer type impingement, which means the acetabular rim is probably the egg-shaped portion of this. Now, FAI tests, one thing that differentiates an FAI and an osteoarthritis patient is Fai is usually positive in patients with osteoarthritis, Fai is usually positive in patients with an impingement, and the age is usually about 50 years different. That our FAI patients are often people who are fresh out of college, they're young, they're athletic, as opposed to somebody who might have arthritis, has a few extra years under their belt. The next thing that we'll think about is the labral issue. Could there be a problem with the lip of cartilage around the labrum? So there are a couple of tests that can help. One, if you flip back to your back again, and obviously in our orthopedic assessment during a clinical presentation, we're going to try to organize this in a way that the patient goes from a standing to a sitting to a prone to a supine. For the purposes of this video, we'll flip around a little bit more so that we can go diagnosis by diagnosis. So the Arlington test, what we're looking for here is could there be any irritation to the labrum? So we take this patient from a Fai position of flexion, abduction, external rotation, and internally and externally rotate their leg until we get them over into a Fai position. So we're testing a real whole range of motion for any sign of irritation to that labrum. The other thing that we can do is McCarthy sign. So this is taking the patient up into basically a knee to chest position with both legs at the same time. And now I'm going to grasp one leg into external rotation and take it back down, and then the same thing into internal rotation and take it back down. Another way to provoke a labral issue. And then the last thing that we can do, and I'll demonstrate it here, is going to be the twist test. Now the twist test is taking your legs, bending them 30 degrees, and taking them back and forth as though they're windshield wipers. If it's not positive on both legs, have the patient do that on one leg. This is different than what we're looking at a Thessaly test where we're rotating from the hip. In this case, we're rotating from the knee, so we're taking that back and forth. If somebody has some anterior thigh pain, especially if there's a burning or a paresthesia, we think of potentially meralgia paresthetica, irritation to the lateral femoral cutaneous nerve. So number one, if that nerve is irritated where it emerges near the ASIS, it's going to be tender to the touch. The other thing that it doesn't like, in addition to compression, if you flip onto your side, is, or the thing that it does like, is decompression. So if I apply a compression over the iliac crest, what I'm doing here is giving a little bit extra space for that nerve, and it will oftentimes go away. That test is 95% sensitive for a diagnosis of meralgia paresthetica. The last thing that we can do is to try to stretch that nerve. So if you flip onto your stomach, if we do Yeoman test, taking that patient's knee up and thigh up If that stretches the lateral femorocutaneous nerve and the femoral nerve, and the patient has increased pain or paresthesia, now we can say we've probably nailed down that diagnosis. Most of our patients who have some degree of hip discomfort are going to have pain on the outside of the hip at the greater trochanter. We call that greater trochanteric pain syndrome, and most of the time it comes from gluteal tendinopathy. So there's a couple of great tests that we can do for gluteal tendinopathy. The first one is the hip lag sign. So if the patient lies on their side, okay, I'll stay in this position. If they lie on their side, we're going to take their leg into a little bit of extension, a little abduction, and a little bit of internal rotation and say, hold that. If the patient is not able to hold this here and their foot drops more than 10 centimeters, we're very suspicious that there could be some gluteus medius involvement, either a tendinopathy or potentially even a tear of that tendon. The other thing that we can do is the resisted external derotation test. So in this case, the patient is in a supine position on their back. We're going to take their hip and knee up into 90 degrees, and then I'm going to take their leg into a state of maximum external rotation and then have the patient push out against my resistance. When they do that, if there's irritation in the hip, we're suspicious of some gluteus medius tendon involvement. And the last thing that we can do is the 30-second stance test, which is basically a Trendelenburg that you hold for 30 seconds, saying, is there any pelvic drop? Is there any pelvic unleveling where the patient is now trying to tip over to the side? Or do they fatigue and does their leg drop down over a period of time? Now lastly, as we do our orthopedic evaluation on things that go wrong on the backside, we'll look at the piriformis. So if you flip back onto your stomach, you're getting a workout here. Piriformis number one, we're going to look, is there tenderness in the piriformis directly between the sacrum and the gluteal insertion? The other thing a lot of times that we'll see with our patients who have piriformis syndrome is they'll have naturally externally rotated feet. That those externally rotated feet, which is called the piriformis sign, is somewhat indicative that this patient probably has some piriformis hypertonicity. If the patient has pain on passive internal rotation of the femur, that's another sign that we could be stretching or irritating the piriformis. And then finally the Beatty sign, which in a side-lying position, the patient is going to then abduct their leg off of the table a couple of inches and hold that there. By contracting that muscle for an extended period of time, that could irritate the underlying tissues. One thing that sometimes we overlook with pain in the buttock area is it may not be the piriformis, it may be coming from ischiofemoral impingement. That's where the quadratus femoris muscle, which lives between the femur and the ischial tuberosity, is getting pinched. It becomes irritated, swollen, and potentially causes irritation even down into the leg. So the way we test that one, if you flip back onto your stomach, for ischiofemoral impingement, a couple of different things we can do. Number one, we can go right medial to the ischial tuberosity and poke on it and say, is the quadratus femoris tender? We can also do a long stride walking test, that when we have the patient take a long extended stride and they have reproduction of pain in their buttock, that's 92% sensitive for a diagnosis of ischiofemoral impingement. And finally, the ischiofemoral impingement test is having that patient take their leg into abduction and then lower it. So basically what we're doing is we're taking the femur and we're pinching that quadratus femoris muscle up against the ischial tuberosity. And lastly, we'll look for any signs of hamstring involvement. And hamstring involvement, as we tested the hamstring before, in a resisted fashion, we can also have the patient do a hamstring drag test. They can drag the doormat sign where they're dragging their foot across the floor. I tell the patient, try to rub some of the rubber from your shoe onto the floor. We can do a sophisticated test called the take off the shoe test, which is trapping one heel and then having the patient drag that foot out of there. If those tests are positive, we suspect hamstring, and a lot of times differentiating hamstring from the lumbar spine can be a challenge, but there's one great test, and that's Bragard's test. Lying on your back, if this patient has pain, I take their leg up and they say, ouch, that could be a hamstring or a lumbar radiculopathy. If I drop their leg 10 degrees and then dorsiflex their ankle, if they still have pain, we've basically ruled out a hamstring because we did nothing to the hamstring in that case. So that's a really good test to help differentiate those. The other thing that we'll really want to focus on our patients who have hip pain is a functional assessment, saying what's going on with the hip abductors, especially the gluteus medius coming off the iliac crest onto the greater trochanter. That abducts our thigh, it holds our belt level, and when I bend my knee, it holds my knee into controlled frontal plane. If that muscle is weak, my pelvis drops when I stand on one leg. My knee dives in when I walk up and down a field or up and down the mall. So the way that we test this in office is ask the patient to do a Trendelenburg and then ask them to do a single leg squat. And we're looking for the leg to come straight at us. If it dives in, what's happening is we're constantly stretching the gluteus medius and causing a whole biomechanical storm. Same is true for foot hyperpronation, having that patient walk up and down your hall. If you see that their feet are going into hyperpronation, the same thing is happening upstream. And don't forget to look at leg lengths. If we have a short leg from one side, either structural or functional, that's going to put a lot of compression on one side and a lot of stretch on the other. We'll do our neurologic evaluation, looking at the dermatomes, the myotomes, and the reflexes, and finally we'll look at the lumbar spine. Don't forget that 71% of hip pain comes from an asymptomatic lumbar spine. So we can do our Kemp's and our Yeoman and Knocklas tests. To rule out the sacroiliac joint, we can do a thigh thrust test, which is taking the patient's leg up and then pushing downward and saying, does that cause some discomfort? We can do a sacral compression test where the patient is lying on their side and I apply a pressure over the iliac crest, or we can have that patient lying on a prone position and apply a sacral compression right over the sacrum itself. Those Laslett tests are excellent tests to help us rule out the sacroiliac joint. And finally, saying, is this potentially a radicular complaint with a straight leg raise for the sciatic nerve, or a Yeoman test or a femoral nerve stretch for the femoral nerve? I hope that this quick review has been helpful for you. If you have any questions or would like to review any of those tests, you can dive into the ChiroUp Clinical Skills tab. If you have suggestions about how to improve that exam, I'd love to hear it. Thanks for watching, and I'll look forward to connecting next time.